Hello, and welcome to the Duke Endocrinology Conference. I'm Diana McNeill, Professor of Medicine at Duke University Medical Center. We are glad you have joined us. Today's program is titled Recognition and Management of Foot Ulcers in Patients with Diabetes Mellitus. And our distinguished guest is Michael Kerzner, Clinical Associate in the Division of Orthopedic Surgery in Durham, North Carolina. Michael, thanks so much for joining us.
Thank you for having me.
So, Michael, what can you tell us about today's topic?
Well, foot ulcers in the population of those individuals with diabetes is one of the, if not the leading reason for admission to the hospital, drives up the price of the care for health care for those individuals, and is a very important factor in multiple comorbidities and poor outcomes.
Okay. I think we tell our primary care extenders that if they only have a short period of time with a patient with diabetes, that they should always check their blood pressure and their feet.
Great advice.
And
great advice.
I have trained my patients to take off their shoes even before I walk in the room so they can be ready to be examined.
They will be helped by that.
Okay. And you'll show us why.
Yes, I will. So let's get right to it. I want to start off by talking about some of the economic impacts and some of the more direct costs of diabetic foot ulcers. Healing an uninfected diabetic foot ulcer done with a relatively recent study in 2003 came to about $9,000. An infected diabetic foot ulcer came to rounded up to about $25,000. And healing a diabetic foot ulcer that has bone involvement costs go up over $45,000.
Amazing.
Substantial.
Amazing.
Out of a large study done of almost 9,000 patients, similar findings were determined where the attributable cost for a 40 to 65-year-old patient with a new diabetic foot ulcer is estimated to be almost $28,000.
Okay.
And this does not account for the opportunity costs, which we'll go into next a little bit. Per capita medical expenditure is another way of looking at this. These numbers do jibe with what we talked about. Nationwide, just in this country, we're looking at $4 billion on diabetic foot ulcers and 15 million lost work days.
That's amazing.
59% longer hospital stay.
And in this area of economic concerns about healthcare costs, that longer hospital stay would certainly garner some attention, I think, in many of our institutions.
It would.
So things that we can do to prevent that, you're going to teach us right now.
I hope to.
Okay.
So here's some some of the epidemiology of this condition that I just picked out, some very prominent studies from various sources. Primarily 1997 to 2004, the population grew by 8%, but yet the prevalence of diabetes increased by 50%.
That's amazing.
Yeah, and that's been in the news lately, and I think people can understand that easily.
Right.
That's not an exaggeration. These diabetic individuals have an estimated 15 to 25% lifetime risk of developing a foot ulcer. Now, if you think of that in terms of, well, what's my lifetime risk of developing various forms of cancer and heart disease, they're a fraction of that.
Right, right.
Substantial numbers.
And just so we can be clear, these are patients both with type 1 and type 2 diabetes, and type 2 diabetes is the one that's particularly an epidemic right now.
Correct.
We're talking about both the major kinds of diabetes.
Both types.
Both types, okay.
Right, it's not differentiated between the two.
Okay.
And then finally, limb amputation is 10 to 30 times more likely in the same population group that we mentioned. So mortality following amputation, and this is a point that cannot be driven home enough that I will mention in a few of these slides to emphasize the importance of why diabetic foot ulcers, when seen in the primary care setting, should be treated with just as much weight, attention, and detail as some of what is considered the more serious conditions. Okay. Oh. So, again, this is mortality following an amputation. So we've gone a little bit past the level of an ulcer. These are patients that have had a primary amputation, and this is either major or minor, which is considered either part of the foot or above or below knee.
So just to clarify, even if you just have a couple toes that are amputated?
A single toe.
So this includes that data?
This includes all that data.
All right.
13 to 40% of those individuals will die within a year. And this is based on a multitude of studies out there, fairly well validated through the literature. The numbers go up at 3 years to 35 to 65%. And even more remarkable, one study showed upwards of 80% at 5 years.
So, Mike, what are they dying from? Are they dying from complications from the amputations, or what the amputation represents with regard to their other comorbid problems?
Yeah, I mean, it's a combination of problems. Primarily, it does not have to do with the foot ulceration itself.
Okay.
There are those patients that come in septic and diabetic ketoacidosis, and they're in shock, and their kidneys have failed. But for the most part, these are the other comorbidities that they have. And these are typically very sick individuals that are chronically ill.
Okay.
But they range from ages within their 30s on up.
Oh, my goodness.
Yeah.
And I think the foot ulcer sometimes can be a surrogate marker for some of the other complications people sometimes have with microvascular disease and peripheral neuropathy, as you'll discuss.
Absolutely. Yes, we will get into that.
Sobering statistics.
So this was a very large study done out of Norway. Interesting tidbit about this one is that it was a community design, whereas a lot of them out there are more hospital-based, where they took almost 64,000 patients, closer to 65,000 patients total. I'll go through this because it's kind of wordy. It's 155 diabetic patients with just a history of foot ulcer. Over 1,300 diabetic patients without a history of foot ulcer, and over 63,000 patients that were not diabetic. They were followed for 10 years with mortality as the endpoint. So again, death is the endpoint in the same theme of what we're carried on here.
Okay.
It was all adjusted for all the standard variables. And the conclusion from this was that, again, large study, the diabetic patient with a history of foot ulcer, so they don't necessarily have an active foot ulcer, but a history, is associated with a 47% increase in mortality.
So just so we're clear what we mean by foot ulcer, we have patients that sometimes come in and say, I stubbed my toe and the tip of it isn't healing, versus someone who says, I looked at my feet and I now have an area that looks like it's breaking down from, no clear reason. Are you talking about both of those causes for foot ulcers, or is it the latter one where it's just an unexplained trauma? Or
most of these studies, and what I found in my practice in addition, and with my colleagues that I've discussed this with, it is any type of breakdown.
Ooh.
So it can be a post-traumatic breakdown, it could be a callus that breaks down, or it could be a non-traumatic wound to the foot that's due to ischemia or just neuropathy. And we'll get into the causes more later.
Okay.
So again, this is 47%, kind of is right in between that 35 to 80%. It means when you're sitting there talking to your patient, that you need to tell them when they've got this foot ulcer, not just for the practitioner to take it seriously, but for the patient, that based on this study, you can honestly assess that almost 50% of those individuals will die within 5 years. And this brings us to a rather sobering chart. So again, talking about mortality rates only, because I want to really be able to emphasize the importance of dealing with these things early and aggressively. And I'll work through this. Prostate cancer has, on this graph, about less than a 10% 5-year mortality rate. And people think of prostate cancer, breast cancer, pancreatic cancer. These are serious cancers. Breast cancer, heavily in the news over the last couple of decades for good reason.
Right.
But yet the 5-year mortality rates, based on current numbers, are slightly under 20%. Whereas you take the neuropathic ulcer, and like we're talking about, it's up over 40% on average based on all these studies. That patient undergoing an amputation, slightly above 40%. So amputation is not as critical when we're talking about preventing these things as those patients that present with the ulcers in the primary care setting.
So if you were trying to get everybody's attention for how to prevent these, I think you've done it. I was not aware that the mortality rates were so large in just the ulcer patient. I mean, I think we've always been concerned that once you have an amputation, that sets you up for progressive increased risk of death.
It is remarkable.
These are impressive statistics. You've gotten all of our attention for sure, for sure.
So now let's talk a little bit about the pathophysiology and the pathway to foot ulceration.
Okay.
Classically, it's considered a triad. I added a kind of fourth topic to this because it is somewhat equally important. We've got neuropathy, vasculopathy, immune deficiency, and trauma. Okay. Trauma is in quotations because, to a certain extent, like we talked about before, they can be directly traumatic, but most of these are trauma because they have underlying deformity. they can't feel very well, and they get breakdown and they don't know it.
Okay.
And then everything else kind of comes into play after that. These are some examples of various anatomic locations where these wounds can occur.
Now, looking at your pictures very quickly, because we try to teach our residents this, by looking at the location of the ulcers on these photos, can you tell which kind of ulcer it is?
You can get a really good clue as to what it is by location. In the first picture where it's on the side of that second toe, odds are that is a combination of an ischemic ulcer and a deformity and an overuse type syndrome where you get some underlying bony prominence in the web space. It causes some tissue breakdown. The patient doesn't feel it. A few days later, they take their sock off. They notice some drainage. A lot of times at that point, it's too late. We've got to get to those patients before then. Kind of similar on the second one where it's at the end of the big toe. Slide number C on there is more of a true malperforans off ulcer where you've got some musculoskeletal deformity. They probably had a callus in that area that just broke down. And then the final one is, the last one is an example of the one before it, where you've got a Charcot-arthropathy. That is a neuroarthropathy where you get breakdown in the midfoot. We can spend hours just on that one, so we'll kind of breeze through that. Ironically, in those patients, the peripheral arterial flow is usually very good, just based on the suspected nature of the causative reason for getting Charcot-arthropathy, and those are one of more pressure from underlying bony deformity.
That's a beautiful picture of a rocker. We call them rocker bottom.
It is a true rocker bottom foot.
Right.
Very difficult to manage.
Yes, it is.
And very poorly recognized, I would add.
Right, but we, in diabetes, consider it an endocrinologic emergency if we see it, so we would send them immediately to people like you to help us out.
Right, and hopefully we can get them before then.
And
I just threw in, when this patient walks through the door, I kind of reiterated in red to make it a little more bold. This is that patient that you've got to say, listen, nearly half of you are going to result in death within 5 years, so please, if you're not going to listen, this is what you're dealing with. Yeah, it's a little bit different when you deal with that smoker with early emphysema who could still live a long life and not take it as seriously. So in the evaluation of a patient with a diabetic foot ulcer, obviously there are many facets that you've got to look at. We're going to kind of go through these rather quickly, but you want to look at evidence of systemic illness first. Fevers, chills, sweats, nausea, vomiting, hypotensive tachycardia, their nutritional status, including all laboratory evaluation, to determine whether that patient needs to be hospitalized or not.
Do you all use the CRP? And could you define why and how you use that when you're trying to evaluate a patient with foot ulcer?
I still do use a CRP and a sedimentation rate. I think it is still more experimental and doesn't lend itself very well towards any type of treatment algorithm. But I think it will. So for right now, I think it's more experimental.
And just for clarification, the CRP is a C-reactive protein, not a C-peptide, which some of our patients get when they're trying to be assessed for insulin secretion. People get that confused sometimes when they order the lab.
Yeah, this is more similar to the high-end CRP that is used for cardiovascular disease. But for us, it's more evaluation of an inflammatory response within the body. We know these patients are immunocompromised, and sometimes it's difficult when they are infected because they don't mount that same immune response. So this is a more critical way of trying to look at that. Risk factors, second thing in the category, are diabetic peripheral neuropathy. This is where your Semmes-Weinstein monofilament testing comes in, which we'll go into a little more detail. Peripheral vascular disease you need to look at. We'll go into more detail with that. Something people don't think of as first-line practitioners is visual impairment. We tell our patients a lot of times, please inspect your feet daily. Look in your shoes. They may not come back and say that they have some visual impairment, even if it may be in the medical record. So that's something that's got to be addressed. If there is impairment, then you have to tell them, look if you can. If not, take your hand and feel it.
Or have a family member look, which a lot of our patients will sometimes do.
Exactly, and I sometimes give out mirrors. To help with that also. Renal disease. Historically for me as a surgeon, renal disease is a poor prognosticator for outcomes. But it's something that can be and needs to be addressed if you're going to heal these wounds. Poor glycemic control, obvious. Smoking.
Yes.
It would seem absolutely, crazy that these patients would smoke, but of course they do. You've got to aggressively pursue smoking cessation modalities for that.
Right.
Obviously, underlying deformity, with or without Charcot, you've got to address those things, previous amputation and ulcer history. As far as the inspection goes, you want to look at bone prominences, whether they have superficial fungal infections, which can then lead to areas of breakdown. Most of those infections in a mildly immunocompromised host are not going to cause deep-seated infection, but certainly that's possible. Many times I culture for fungus too because they are compromised.
Do you culture the nails if you see fungal nails, or are you culturing the tinea pedis that you see? Because we have so many of our patients that have onychomycosis, the fungal nails. A lot of us will empirically treat. Most of the treatments are not easily tolerated, as you are probably aware, because they have to be regularly taken and liver function tests sometimes monitored. But you culture selectively?
Very selectively when it comes to
selectively.
superficial fungal infections.
Okay.
I would say those things need to be aggressively treated,
Right.
but since they are superficial, a lot of times you can use various agents without dealing with cultures, which are only so accurate in this patient population.
Okay.
But you do have to aggressively treat them.
Okay.
Yeah. Structural deformities and contractures need to be addressed and evaluated because that's what leads to breakdown. Look at their color. Look at the swelling, any other cutaneous changes. All these things can be evidence of other systemic disease.
Okay.
But in the diabetic patient population, we're talking about reducing the risk of ulceration. Not really focused on that here.
Okay. The only procedure we have in diabetes you're about to discuss here. So.
Yes, and it's really interesting.
Yes.
There were some things that I discovered in looking into it that's a couple of things I threw down there. But the question is, how accurate really is it? Because it is so widespread.
Right.
I kind of wanted to approach it from, here's not what you do.
Right.
But let's look at this in a more critical way, if not briefly.
Okay.
So it was first described by von Frey in 1899 using horse hairs, which was fascinating to me. I could not believe that it took us, civilized society with modern medicine, over 100 years to really use this aggressively. And the classic study by Burke and Sims determined that it was the 5.07 diameter one that gave us that threshold that we can use. But that being said, some of the more recent studies that as an isolated agent, it actually isn't that useful, and you can miss some diagnoses of loss of protective sensation.
Can you take your hand and show our audience where you would check with the
there are some classic examples of it, and based that if this part of my hand is the heel, here's the big toe, the middle toe, and the little toe. Here's underneath the metatarsal phalangeal joint area. Essentially, you want to at least test 3 of these areas, but when you test them all, you want to hit under the pulp of the toe of the 1st, 3rd, and 5th.
Right.
Typically, the 1st and 5th metatarsal phalangeal joints, and then the heel.
Right. And don't let the patient be staring at you the entire time you're doing it, because they will always say they feel it. And then
it's got to be somewhat blinded as best you can.
And these, you don't have to get a special monofilament. These are given out often, or they're present in clinics. So people, is there a special kind you have to buy?
There is no special kind. I would say some of the commercially available ones are inexpensive. They're easy to get to.
Okay.
But the later studies are showing that it kind of has to be combined with a tuning fork or a reflex hammer to really hammer down and not miss the small percentage that can be missed by this.
Okay.
Yeah.
Okay.
And in the vascular exam, at least in a clinical setting, upon initial presentation, you want to look at their pulses, skin temperature, color, whether they have increased distal cooling. Everybody has that to a certain extent, but if it's substantial, you want to notice that. Press on the nail plate, see how soon it pinked up. That's the subpapillary venous filling time. Ankle brachial indices are kind of standard of care for those of us in wound care because that gives you a general assessment. We'll go into a little more detail. TCPO2s give you an assessment of the oxygen concentration.
Those? How do you do those?
That's like a small little plastic probe that's placed on the skin. And there's a little bit of saline that's placed on the cup in the center of it.
Okay.
And then it kind of measures the oxygen concentration just below the skin in a kind of layman's terms.
This would not be something necessarily that a non-wound care team or?
Typically not.
Okay.
Typically not. You know, it is very user dependent. I talk a little bit about it later on.
Okay.
But it does give a great assessment of the cutaneous blood flow distally that you can't get from other non-invasive testing.
Okay. Okay.
And it's still non-invasive.
All
and then there's segmental pressures and Doppler. Now, the ankle brachial index, which is easy to do, low expense. You can get an ancillary provider to do it in your clinic. It's inexpensive and it's rapidly available, but it does have some limited reliability because a lot of these patients have calcified vessels, in which case they lose the elasticity. Well, the whole thing is you're compressing this vessel and then seeing what that flow comes back as.
Okay.
And that's what the pressure gauge is measuring.
Okay.
So if they've lost their elasticity within the vessel wall, it's not going to be accurate. So that being said, 1 is normal, and anything above or equal to 0.45 is what you're looking at.
Okay.
In a compressible vessel, that's what you're looking at. If you don't have that, which is needed to heal a diabetic foot ulcer, odds are you're not going to heal.
Because you don't have blood flow going down.
Correct.
Okay.
TCPO2, again, measure of oxygen level just below the skin. Very sensitive but user reliant because you don't know if you've got good suction from the probe that's there. You don't know if your saline's got flushed out. So it's very user dependent on that technician that's applying those probes there. But it's easy to determine that. And the numbers from that are much more accurate, and anything greater than 30 millimeters of mercury read is, you know, an 86% or higher healing rate.
Okay.
Toe partial pressures, which I happen to favor,
All right.
and not every vascular facility does them. We do have them available at Duke rapidly, easily. It's a beautiful thing in my clinic when I can get that full dietary, vascular, nutritional, laboratory, and clinical evaluation right then and there. We can really help these patients rapidly. That being said, anything less than 40 millimeters of mercury, not going to heal, 36%.
Okay.
And you need at least 45 millimeters of mercury. Same as it is for segmental pressures just within the toe.
So for many of us who refer patients to you, we sometimes wonder how the decision is made to amputate. And what I'm hearing from you indirectly is that you take a large body of evidence, put it together, try to decide if there's excellent chance for limb salvage, because you all are limb salvage people, and then decide with the patient and their referring physician what the best course of action is. It's not just one piece of data.
Correct.
Am I understanding that correctly?
Very correct. And truly, it isn't just our decision. Sometimes it's a combination of what's best for the patient, for what their activity level is, and with the vascular surgeons that are out there also.
Okay. Because a lot of times we get reports back that have all this information you just have gone over with in the report, and I think a lot of primary care extenders, even endocrinologists, sometimes are not sure how to put it all together, and patients ask us what we think they should do.
Right.
So,
well, I hope I'm giving you a good
you're
summary.
doing a beautiful job. Beautiful job. Now the probe to bone.
Yeah, this one is relatively new. The initial study came out in the mid-1990s. I personally like the test to use in a clinical setting because it's easy to do. Sterile Q-tip. You've got a wound that probes to bone. In the right setting, you can feel pretty certain that there is bone involvement in there. We know most of these, I did not really get too much involved with infection, but we know that most of these wounds are at least contaminated just because of the immune status of these individuals, usually the chronicity of the wound, the necrotic tissue that's there in the wound. So the initial study made it more of an adequate measure of wound depth, and you couldn't really use it because the sensitivity came out to only about in the 60 percentile range, which is not very useful in a clinical setting. But Lavery and Armstrong in 2007 did a much broader study and determined that it has a low predictive value, but can exclude that diagnosis of osteomyelitis, which is really what most of us, and I use particularly, because if it does not probe to bone, although you still can, your odds are much less. I tend to combine the probe-to-bone test with plain film radiographs, clinical signs of infection,
and a SED rate. The SED rate.
We're going to tie that in. We're going to get some better use out of that. So, I tried to limit the amount of gore in this presentation, but this one was just too hard to resist. This is an individual I saw not that long ago, middle 60-year-old gentleman at the hospital, because I was paged that morning to see him prior to discharge that same day. They found a little wound on the bottom of his foot. He was obviously here for other reasons.
Right.
As you can tell just from the initial look at this, there doesn't seem to be anything remarkable. It's nothing really impressive. There's no foot that's swollen, red, hot, and lava flow of pus
Right.
draining out of it
Right.
at the moment. But they were concerned there was a superficial, kind of granular-looking, non-impressive ulcer on the bottom of his foot that they just kind of wanted me to take care of.
Okay.
So you have to be careful with assumptions. This individual is very lucky that his attending physician at the time took the time to do this. I lost my arrow. There we go. So I'll kind of talk you way through this. So this is in the operating suite. There shouldn't be much sound with this. And I'm going to actually probe this. It's what I do a lot of times because you just never know. And I think it's always a mistake to assume.
Patient's awake.
Yes, this is a neuropathic foot. So the initial probe, and you can see by my finger, we did measure it later on, but it's about 2 centimeters there.
Oh, my goodness.
For a wound that if you looked at it earlier, a little too much light there, but when you looked at it earlier, it didn't look like it probed anywhere.
I would have guessed people would have missed that wound as just a healing ulcer or a callus.
Very easily, because it could have just had a scab on it.
Because he didn't complain of any pain.
Exactly. So let's let this last just not too many seconds longer. And what you'll see is after we open it up and then probe it, you can see that pus draining out of there from some deep space infection. Now, ultimately, he ended up staying in the hospital for about another 2 weeks. I ended up having to stage his procedures because there was such extensive necrosis that it could never be closed every time I brought him back, and a definitive amputation could never be done. And he ended up doing very well with a transmetatarsal amputation.
What would you, as we are finishing this video, advise our primary care physicians that we could have done differently here? Or what can they do?
Here's how it goes in a little bit deeper now with this probe. And this gets measured. What can be done for something like this is just don't make the assumption. You see somebody with a diabetic foot ulcer.
Powerful.
Get the consult.
Okay.
Have somebody really inspect this thing. It's not the only time it happens.
Feet. Look at the feet. Always look at the feet. Okay.
This was an interesting study by Dr. Edelman in diabetes care in 1996 that I was not aware of myself, one of those tidbits that I found. Primary care physicians are not using the patient history to evaluate diabetic foot ulcers. They're relying on x-ray changes. And just to kind of go through this quickly, most of the time they're making the referral because these are non-healing wounds, there's necrosis, and they have or haven't found something on the x-ray. Scans are very useful. Right now the MRI is the current standard. These are the things you want to do to evaluate the wound, look at the size, the depth, again probing it, see what kind of tissue's there and whether there's signs of infection.
Now is this, you are telling our primary care extenders and endocrinologists this is what we should be doing, right?
If there's a certain level of comfort and experience there, they should. If not, then this is the information that the surgical specialist needs to get out of it.
Because some of our listeners are probably not going to have access to people like you. And so I guess one of the things you could help us with is knowing when we have to find access to specialists.
Right. And I want to skip that for right now because there's a really good point later on about when to do that.
All right.
If you're going to treat these, if you don't have that referral source.
Okay.
There are a few wound classification systems. The one that has taken into account the most use, although not fully validated, is the University of Texas at San Antonio classification system. And for the sake of time, I won't go through that, but this is the one that most of us should be using, if not already.
Okay.
So, getting back to your question.
All right.
What is it when that primary care physician sees the wound, feels comfortable with it, says, I know moist wound healing is the way to go. I'm going to make sure it drains into something but keep the wound moist. I'm going to make sure it's not infected. I'm going to make sure it has good blood flow. But at what point when it's not healing, where's my danger point that I should think, I need to send this out before it probes the bone?
Okay.
And what has been determined over the last few years, and by these studies, here's an ADA consensus conference that was done, and also Dr. Sheehan, very, very well respected as early as 2003, but really just being incorporated now, is that the 4-week 50% rule. If it's been 4 weeks, and you've done all that other stuff, their nutrition is adequate, their albumin and pre-albumin is good, they have no major deformity, they're being offloaded appropriately, which we haven't talked about treatment, but they're being offloaded appropriately. You've got that moist wound healing. Patient is not infected, and it's been 4 weeks and they're not healing, you've got to let that patient go and refer out for more aggressive measures.
Okay. That's a pearl. We call those pearls because I think for a lot of us, we're never 100% sure how soon or how late. I would say if you're not sure, refer. But I think this is a good guideline for a lot of us to take care of patients with diabetes and foot ulcers.
So therefore, trying to get to the end of this here, if it has been 4 weeks without measurable improvement, measurable meaning 50% or greater, you're measuring those margins in depth, refer to adjunctive modality or treatment. This is to go over some of the treatments, but just to skip ahead to number 8, when it gets to be those 4 weeks, that's what we got to do, the more advanced stuff. Not necessarily surgical, but the bioengineered tissues, the Regranax gels that have growth factors in them, and more advanced offloading techniques like total contact casting when they're not initiated earlier.
So, in summary, tell our primary care physicians what they can do to prevent diabetic foot ulcers or prevent them from worsening into the amputations that give us the mortality that you were describing.
Well, I think it goes back to what you said originally, is that they need to have the patient be educated about this and inspect their feet both with their eyes, with their hands, with family members and friends, whoever's willing to do that. Glycemic control, maintain that. In addition, when they have the wound and they have breakdown, address it aggressively. And if you're not comfortable with that, refer it out.
All right. Michael, thank you so much for a great discussion. You gave us many, many things that I think will impact, hopefully, our patients with diabetes. Our guest today has been Michael Kerzner, one of my colleagues here at Duke. And again, thank you for joining us for this great discussion. Until next time, then, from all of us here at Duke, this is Diana McNeill saying thanks for joining us and take care.